So let's start just by putting your name, pronouns you use, and the organization that you represent into the chat. And I'll also put those in here so that folks have a sense of what you're doing. And then also, how about 2 words to say how you're feeling today? And then we'll get going in just a minute. So name, word. Okay. All right. For those who just joined, I will drop the thing in the chat a couple more times of what we're doing in the chat. And for folks who are presenting today about vitality signs, this is really for you so that you have a sense of who's in the space and what they're up to. Okay. So I think I know almost all of you. I'm Kara Drury-Kennedy with Co-Thrive. I'm not going to do a whole lot of updates for us today because we've got a robust presentation on the Vitality Signs Project, but did just want to, I'm seeing a lot of familiar faces who I love, so it's just good to be in the space with you all. And, we're kind of in the pregnancy space right now, I would say, with Co-Thrive. So I think things are moving and shifting, and exciting news will be coming soon, I think and hope. So with that, I'm going to pass the presentation over to Linda Niebauer today, who I think is going to be sharing this slide so that the Vitality Signs Project can, I think there's a number of folks who are going to kind of pop in to talk about this project. But really, part of what we've been struggling with in Co-Thrive is not just how do we define and measure thriving, but really what does it look like to have multiple individuals who have different experiences of thriving and different definitions of thriving, and different lived experiences try to all be measured in the same way. And it's kind of one of those wicked problems, and yet needs to be solved in order to be funded in the world that we currently live in. And so the Vitality Signs Project is one of the projects who's really trying to wrestle with that. And I'm excited for us to all learn about it together. So with that, I will be quiet for the moment. I can't make any promises about long-term quiet. And then I will pass it over to Linda. I'm gonna, again, if you just joined the meeting, I'm gonna put what we're doing in the chat back in. Okay, thanks y'all.
Okay, I just would like to say good morning to everyone, and it's terrific to see so many familiar faces. I've kind of been away from this group for a bit, and I'm Linda Niebauer. I work with the Farley Health Policy Center, and I'd like to introduce the other 3 folks on the screen here who are also working with me on the Vitality Signs Initiative. One is Frank Degree, and I know you're all quite familiar with Frank. I don't know that he needs much of an introduction, but he's been with us on this project, and it's really been fun. It's been challenging but fun. Doug Fernald is he's a extraordinarily great qualitative researcher. He's with the Department of Family Medicine, but we steal him away every chance we get to work with us. And Mara Gisson is also with the Farley Health Policy Center. She's a graduate research assistant, and she's in the clinical health psychology program. So with those introductions, I'll try to share my screen here. That's been a little tricky. Let's see how it goes. Can you all see the slides?
Yep, they came right up.
All right. Let's see, we need to go back to the top, I guess. I don't know why it started there. There we go. Okay. So just a little bit about what we plan to do today. We want to talk about what exactly is the Vitality Signs Project, share some findings from the literature review, talk about the challenges and tensions that we've experienced in doing this work and provide some impressions from the 3 Colorado focus groups that we've held so far. We've got another one, but we've done 3. And then at the end, we really would love to hear from you, just sort of your impressions and reactions and suggestions related to this effort. In terms of the project, it's a 3-year cooperative agreement, and we're closing in on the 2nd year. We do this with the Centers for Medicare and Medicaid, and it's a partnership that involves the Farley Health Policy Center, colleagues at the Virginia Commonwealth University, and Case Western Reserve. And the aim is broadly to develop a new measure of a person's whole health. And different aspects of that aim involve doing this literature review that you'll hear more about, crowdsourcing and focus groups to kind of test out language and understandings of the concepts. And then we will host a collaborative conference next year to ensure that the survey is pragmatic and actionable in existing regulatory and payment environments. Then we'll create the survey and test it for validity and feasibility of use. And then the dissemination involves fielding the survey, translating it into multiple languages, apply for measurement endorsement, and then ultimately publish the findings. So what I'll do now is turn this over to Mara so she can talk about the literature review.
Great, thank you so much, Linda. Yeah, so I'll just give you all kind of a bird's eye view of the literature review process and some of our takeaways. So we conducted a systematic review of instruments and articles related to aspects of whole health, and we used the HAPI database, which is the Health and Psychological Instruments database, to search for measures, as well as PubMed, Google Scholar, a Gray literature search, and the snowballing method for articles and other resources. Ultimately, over 400 instruments and articles were included for our review. And of note, most of the instruments from the HAPI database that we found were specific to a single domain, which I'll explain a little bit further in just a moment here. Linda, if you don't mind, just next slide, please. Thank you. So the reviewed articles and measures were analyzed thematically, and concepts were extracted and labeled as various domains. So that's what you see over here on the right, these domains, and that's what I was speaking about just a second ago with those measures found from the HAPI database. So most of those measures pertaining to whole health really only covered 1 to like 3 of these different domains. They weren't typically covering all of them. Using a grounded theory approach, we iteratively updated domains, recategorized them, and created new domains as they were identified through the literature review and through collaborative discussions across the research team. Also, given the interconnectedness of domains, the creation of overarching categories were implemented to categorize domains into more primary concepts. So here what we're kind of seeing is, if we look at these first few, we see physical well-being, mental, emotional well-being, meaning and purpose, or spiritual well-being, sexual well-being. So while these are distinct domains, there's quite a bit of overlap amongst them. And so thus we categorize them into kind of this larger bucket, which we called body and mind. In addition to the purpose of determining domains and subdomains of whole health, another purpose of the literature search was to examine decision points and instrument design related to features. So with this, we're thinking about things like frequency of administration. Were the measures administered at every visit? Were they administered annually? Thinking about things like the question response type. Were Likert scales used? Were they open-ended questions? A combination of both. So those pieces as well. Next slide, please. And then lastly, I'll just review a few of our key literature review takeaways. So there's a lack of consensus in how to measure whole health. So this poses some problems that we all know, such as kind of confusion for providers about which measures to use. There's not really one recommended measure for providers to use, which also leads to inconsistency across care. There's also an opportunity to develop a new whole health instrument to better support a shift to whole health care. So there is real opportunity here. And then change in payment, care delivery, and the ecology of measurement are needed to successfully transition to whole health care. So while a new measure and implementation of a new measure shows great potential, there are significant limitations that I'm sure we all know about within the healthcare system and other systems that pose potential challenges with already existing measure implementation. And then even if we were to implement this new measure, that would still be there. And so in order for such a measure to really meet its full potential, system level changes would also need to take place. Okay, next slide.
Okay, so Frank's going to talk about the tensions that we've experienced here.
Okay, thank you. So as you can imagine, in fact, as you've yourselves experienced, I'm sure, trying to learn whether someone is thriving in all of the dimensions of their lives in all aspects often requires that we have a common understanding of what we mean by thriving. And as it turns out, what we as service providers or as clinicians or others in the helping professions mean by that, and what people who are out in the world living their lives mean by that is sometimes quite different. So the very definition of comprehensive whole health and thriving, there's no agreement about that. And so part of our first problem is reaching some sort of agreement. That has very much to do with the part of this project that Doug is going to talk with us about in just a moment. Another problem here is that recognizing that health and thriving ramify into a whole bunch of different territories, it takes a while to find out how people's financial health, how their social health, how their emotional health, and all of the physical health are. And the time that it takes to do that is often more than we have available to us to learn. So on the one hand, we want to be brief so that we can get about our business. On the other hand, we want to be comprehensive so that we're not just learning about a narrow slice of health. One of the things that we've been discovering is that in trying to reduce the dimensions of health just to something that we can quantify or score, the important nuances that people have to tell us about how they're thriving and what's not available to them requires more of a conversation. And so we want to make sure that we not only learn how the extent to which they're thriving, but what it would take in order for them to reach the next higher level. Yet another problem is that people's circumstances have everything to do with how they define and what they need with respect to their health and thriving. It's one thing to have a conversation with people about who are relatively well off financially and live in an assisted living community, and another to be having the same conversation with people who have major needs at survival level across many domains of their health and thriving. And in order to be flexible enough to span that range, then it's very hard to create a standardized set of questions or even categories. It's also hard to, excuse me, it's also hard to standardize when people's status is continuously changing. People who suffer, let's just say, for example, a severe physical health problem, but are healing, have a way of describing their health that's very different from people who are facing a health problem that is not in the process of healing yet. And so the longitudinal nature of episodes of health and episodes of care causes this to be very hard to standardize. One of the things that we've learned, Doug may touch on this in just a moment, is that people are very sensitive to how well they know the person who's asking and how much they trust them as to what they tell, what they say. And so the matter of the relationships in which these sorts of assessments are occurring matter enormously. People just aren't willing to talk about certain things with just anybody. There are obvious cross-cultural issues. I probably don't need to elaborate that. We've become quite sensitive to those. And so I'll leave that. And then the issue, one of the issues for us has been, we want to make sure that we're not just asking questions to learn answers, but instead are asking and having these conversations so that we can participate in helping and doing something about it. And so the implementation and how to use this in practice is a very important issue that shapes the nature of the queries that we make. Okay, thank you.
Okay, so Doug, he's going to jump in here now and talk about some impressions and some themes that are coming out of these groups.
Yeah, good morning. And as it says in the title of this slide, these are early impressions. They're not results, so don't take these to the bank. Next slide, yeah. So as Linda said, we're doing focus groups around Colorado. We've done 3 of the 4 we have planned, and they're roughly in those areas you see on the map. And we're generally asking people to talk about and think about their health and how they describe it and what they think it means to be healthy, all the things that go into health, how we ask about it. And what I'm going to share are just very high level impressions. Frank or Linda, jump in with your anecdotes or other thoughts to add to this. But I do want to leave time for questions. So we didn't ask people directly, what is health to them, but they did to talk about it in the course of the conversations. And they described the different components that contribute to their health, the physical, emotional, mental, spiritual, financial. There are a lot more details, and it is essentially what is in the literature when you think about a definition of what goes into whole health or all the things that contribute to a person's health. And so I don't think we're plowing any new territory there, which kind of makes sense because we are not the only ones looking at this, and folks have been looking at it for years. But the participants so far generally affirm what's in the literature about these different components. We did ask, though, what does it mean to be healthy, or what is it like when you're feeling good? And one of the things that came up across the 3 groups, more or less, and there's a typo there in the bolded text, it says, there are common ideas about being able to do the things I want to do. And that's even with older folks who have new physical limitations that might keep them from doing things they did previously or might slow them down. Or something due to an injury or illness, it's still being able to do the things you want to do, whatever it is at whatever stage of life you're in. And for if folks live in the Roaring Fork Valley, one of the things they want to be able to do is ski. That came up, and that's like the marker for, yeah, I'm doing okay, I'm doing pretty well, even if you have to wear oxygen while you're skiing or take off your oxygen while you're skiing. So being able to do things you want to do. And then again, this stuff's in the literature, but affirmed in our focus groups is people want to have a sense of purpose, that they're contributing and doing good things, have social connections, and then just the absence of different disease or problems like anxiety, physical problems, stress, financial distress, things like that. So that goes into this equation or thinking about what it means to have health or being healthy. Next slide. Another set of questions we asked about was what people are thinking, what goes through their heads when they think it's time to go to the doctor. When do you actually make that decision to try to schedule a visit? And this was a little bit to get at kind of the expectations for what's going to happen when they go to the doctor. Most of them described having a specific reason. There's a specific problem they want to address. And it's often when it gets to the point where they can't figure out how to fix it on their own, or it's not going away. And relating back to what it means to be healthy, it's really when that thing, whatever it is, starts to interfere enough in their life that they can't do what they want to do. So it kind of gets to some point. And one person quipped that their bank account tells them when they can go. So do they have the financial resources to take care of something or try to schedule a visit? So again, that financial component. I think most of the part, this was pretty clear, is going to doctor can be a nuisance. It takes their time. It can be expensive, takes money. There are a lot of things that can go along with trying to schedule a visit. And they recognize that time is precious, not only their time, but they pretty much everybody described doctors being really busy. And they want to make sure that at least that reason they came in for gets addressed. And there may not be time for a lot of other things. So that's a kind of what goes into thinking about going to the doctor. Next slide. The other question we asked is, how do people respond to this question of how you're doing? And how would they respond if how you're doing really is like the shorthand that we use for trying to get at what's really going around, what's your thinking about all of your health? What are you willing to share when you get asked this question? And I think in the last focus group we did, somebody summed it up pretty well. This is a generic question and you're going to get a generic response, and others described it as kind of a throwaway question, or it's not one where people have any investment in. It's just kind of a way to start the conversation. And so asking that question is probably not going to get a really deep answer. Along with that, participants described kind of their assessment of the context before they respond. Like, well, who's asking? Is it a friend, a doctor, somebody I kind of know, somebody I don't know at all, my boss? And then they kind of think about, well, why do I think they're asking about this? And do they really want to know? And do I know them? And do I trust them? And this came up in the context of, visiting the doctor. How long have I known this doctor who I'm seeing, or this person in the healthcare setting I'm in? Do I trust them? Do I have some kind of some personal relationship with them that I trust that they really do want to know, and that I can share different components of my health versus that specific reason why I'm there to see the doctor? And do I think they really, really want to know more? Even among friends, like, yeah, they probably don't really want to hear my whole health history again. Or maybe I just had something serious happen and they really do want to know how I'm doing, and I'll get into the details. And then, as Frank mentioned earlier, is there time to say more? In the context of a doctor's visit, maybe not. All right, next slide. I think this is the last slide. So the last question we ask is, well, how do we ask about a person's health? All of it. So we can try to get a more comprehensive picture of what's going on in their lives. And one of the things is, again, these are impressions. So Frank or Linda or anybody else disagree with me, or add nuance to it. But you have to kind of create the right context with trust and genuine interest, or at least be able to show that you really are genuinely interested in hearing more about a person's health and different aspects of it. And you probably need time to do that. So that's the context. You need to ask differently. That generic question is probably not going to do it. Maybe a survey is not going to do it. And the timing has to be right. And it's probably after you've taken care of the reason I came to see you specifically. And then how you ask, the question you ask, and it could be something like, I think we got some good suggestions, like, what else is bothering you that's interfering with you doing the things you want to do? Language like that gives the opportunity or invites the response if somebody's willing to give that. But we also heard that sometimes folks just don't want to talk about all their health. They really just want to take care of what's there. They don't want to get into details about other aspects of their health. And then if you ask me only if you can really do something with the information you get, I think there's a sense, and that's kind of the last point there, that the participants overall are pretty skeptical, but with how things are set up currently, it's just not too feasible. There's not enough time or ability to act on the information to really get a more comprehensive picture of somebody's health. So I think that's the last slide. Yeah.
So Doug, one thing that I would add is I remember hearing this, that it really is about body language and the environment when it comes to asking a question and then getting the impression that person really wants to know the honest to goodness frank answer, right? Like you turn away from the computer, you lean in, you kind of continue to ask questions a little bit differently just to make sure, you're really getting their impression or their learn about their needs at that particular moment.
Yeah. Or if the patient wants to initiate the conversation, we had somebody describe an instance where he moved the chair so that when the doctor came in, they really had to sit facing them. So it's like, come on, pay attention to me. I thought that was great.
I thought that was great too. So Frank, I'm going to turn this segment over to you, and then I'm going to stop sharing the screen so that we can have a discussion about what we just talked about.
Okay. So Mara was basically undersold the extraordinary amount of work that went into doing this literature review. Yes, there were only about 400 instruments that they seriously reviewed for psychometric properties, but there were tens of thousands of papers written about health and thriving that have some or another aspect in there. Almost all of those were scanned, at least the titles, to see if the content was. The world literature is all over the place, and reviewing this and trying to pull out of it the nuts that make sense for what does it mean to say that a person is thriving or is thriving more completely than they were last year. That literature it runs to millions of pages. And reviewing that and making sense out of it was an enormous task. And what Maura came down to, Maura and the others that were part of that team doing the literature, was really that there's probably never going to be such a thing as a questionnaire that you can use to measure someone's health or thriving. The way people talk about it depends on who they're talking to and what they think you can do for them and what's most important at the moment. We literally talked with people who considered themselves healthy even though they ski with oxygen because they can still ski, so they're healthy. We also interviewed people who had a good grip on all the dimensions of their health, but the prospect of spending $30,000 a year on chemotherapy was daunting to them, and their financial health was at risk because of that, and they didn't consider themselves healthy. So the nature of this work has been such that it requires a conversation. And that conversation requires sensitivity to the context. And that context has to take into account what parts of their function people are concerned enough about to actually consider it a hit against their health and thriving, whether they think you can do any good, whether they trust you or know you, and so many factors that this is not going to be a questionnaire or an instrument or a survey. It's likely to be a conversation. And what we're likely to come out with here is a set of conditions and a set of conversational stems and leading questions and what to do with that information. So this is turning out to be a scary, enormous, and messy project that we're going to work for the next year trying to get closure on. So with all of that context, what we would like to do is hear what you have to say and what you think and what your advice to us would be and what your reactions to this are. I see it looks like Glenn under Kristen's name has a question, and then Kevin are who I see so far. Kristen, Glenn, go ahead.
Okay, so wow. To begin with, great presentation, enormously important topic. And I think I'm going to kind of phrase the question in a couple paragraphs and hopefully by the end have a single question. So the dynamic is the way that I understand it, and I agree fully because we're working on this as well, as saying we have a medical model within medicine that we work with. It's disease oriented. People that we paraphrase by calling them patients live in a functional world, not in a medical model world, and that we are attempting to shift our focus away from the disease-oriented world to a functional world, which is, again, more patient-centric. How do we do that? How do we capture their level of function, or however we want to label that, thriving? And what are the components that lead to that? Now, if we look at the social sciences or the social world, that's all they do is the functional world. Currently in the medical world, all we do is the medical model. So we are trying to truly bridge those to help each individual function higher or thrive. Now, in the medical world, we need to be able to document some of this. We need to be able to document it for billing. We need to document it for insurance companies. We need to document it in the EHR for a number of different reasons. And that becomes onerous unless we either have some type of screener that is identified as such, or a bot asking questions. And the questions are important. And the reason I throw in the bot is that, as you guys outlined, it's difficult to find the time. Now, in doing this, we also have to appreciate that probably none of the medical model people, because we're somewhat limited in our social skills, can truly assess if someone is functioning well and thriving, because most of the docs don't really care. They just care about the medical model. So by asking some type of screening questions helps us identify a slap in the face. I am not doing well. I am most interested in skiing. I don't care if I ski with oxygen, but I can't ski. So I am not doing well. So we need something there, appreciating everything that all three of you guys said, that the screener, the bot, is never going to give us the answer. So ultimately, the questions are, how do we get to this functional level if we're not doing a screener? How can we include the information that the person is telling us from a solo standpoint, a family standpoint, a community standpoint, to help us frame the entire care team? How do we communicate with the care team? What are the steps to take the vitality score to the next level and saying, okay, we now understand you as a human. How can we support you? How can we help you thrive? And that's, I think, the question that I'm trying to frame. And hopefully that makes sense.
Yeah, that makes sense. Kevin.
Trying to learn how to unmute myself may indicate whether or not I'm vital and in good health. Congratulations on the work and the presentation, because I find it really thought-provoking, and I thank you for that. It seems to me that there's a couple of observations and maybe a few questions. First of all, I would divide this challenge generationally. I think we have a different challenge in healthcare dealing with older patients who may view going to the doctor in an entirely different way than the younger generations. And so how do we orient the approach to those different generations? That also applies culturally, demographically. There's a number of different slices you could put to it, but I'll focus first just on age. Older people, in my experience, and I consider myself an older person, tend to do what the doctor tells you to do. Younger generations see that as just another data point in my observation. They collect data from different places. The doctor, however they define doctor, is just another point. So I think that creates the challenge in a different way. I also think we need to reorient our patients to what we're looking for in the primary care relationship. I was struck by one of the questions on the slide about, I go to the doctor when whatever problem I'm having is so severe I can't deal with it myself. Instead of, I go to the doctor with the idea I want to keep skiing. I want to be preventive in my approach and look for ways to maintain my health rather than waiting until I get sick. And we talk a lot about the need to avoid preventable disease, and that should be the focus of our primary care rather than waiting until somebody gets sick. I think we also have to consider what the impact of technology. The last comments I thought were spot on, and whether it's a screener or the doc, but there's the ability now to have a continuous transmission of data into the system in order to monitor that health vitality, whether it's remote patient monitoring of some kind. I wear a device on my arm to monitor my blood sugar. There may be other ways that we can feed continuously into a data set. I mean, heck, I can tell from my friends and family sometimes who's doing well or not based on their Facebook posts. Is that a data point that could be gathered to evaluate how people are doing? And I think all of this gets back to the trajectory of health. It may not be where I'm at right now. I really love the example earlier of, you may have somebody who's well off and they're going to look at what their health vitality is in one way versus somebody who's really poor, but who's on a better trajectory, and how do we get them on that right trajectory? And then finally, again, this goes back to my congratulations to all of you, is I think it's really about trajectory. This is maybe sort of one of those things that we're never going to achieve, but we need to keep moving toward. And how do we make sure we're on that path for positive trajectory? So I guess I didn't ask any questions, but just blathered on for a while. But thank you for the chance to comment.
That's okay. Thank you. That's extremely helpful. At this point, comments are equally welcome as questions. Mark?
Yeah. It's indeed an enormously challenging project. One of the challenges is approaching this from the perspective of the interface between the patient's concept of thriving and vitality and the health system, which one of the important questions, I think, in that context is, what is the patient's expectations of their interaction with the health system? And it may change dramatically from one moment to another, depending upon different circumstances. And that might be an important change in perspective that might be helpful to understand how can the healthcare system help people to become vital and to thrive. By studying that interface rather than vitality as a whole. Studying vitality as a whole is probably better done on a group rather than an individual process, for all of the challenges that have been so clearly outlined in the presentations that we've just witnessed. It is so changeable from one moment to another and so dependent upon trust and the way the questions are put together. Whereas on a group basis, taking perhaps a public health approach to the concept of vitality and thriving, you may be able to come up with measures that are more meaningful, but only within the context of the group being studied. Recognizing, of course, that there are many ways to define that group. It may be a neighborhood, it may be a ethnic background, it may be a economic well-being, it could be a religion, it could be any one of a number of different things that we all are members of multiple different groups. But studying people and trying to measure their vitality on the different groups that people are engaged in may be a much more, may provide greater insight into the use of tools that will actually help people to thrive. So those are just some of the thoughts that I came up with.
Good, thank you, Mark. Now, I should probably clarify for this group the nature of the focus groups from which the data that Doug talked about was drawn. In one case, we actually were interviewing people who in a medical practice. In two of these focus groups so far, and the third of the four that we're going to do in Mesa County, these were not medical settings, and these were not medical questions, and this was not about the healthcare system that we were dealing with. These were people who were drawn from community settings other than medical, and the orientation was not the healthcare system. CMS is sponsoring this. They want to know issues about the interface, exactly as you said, Mark, the interface with the healthcare system. But our task, our mission is to learn about people's health and thriving in the most general and global sense that we can. So it went mostly beyond the constraints of the healthcare system itself. And people were pretty good, including in the medical practice that we did, which itself goes quite a bit beyond health care as narrowly defined. They were pretty good about talking about their health in other terms, in other dimensions. That's not to your point, Mark. I think your point is very well taken, that the interface and the nature of group sorts of understandings is very important. But I just want you to have that context that this is not simply about the healthcare system. This is about the most general sense of people's health and thriving. Glenn, you got in again next, and then Kevin.
Mark, that was fabulous. And I think we're going to all agree with all of your statements. This is to the team. We appreciate groups. We think groups are much, much more effective. And we are probably 3 or 4 months into trialing group Medicare well visits. And we have found that a minority of our patients are accepting the group atmosphere. Once they're there, the experience is light years better than if we do a Medicare well individual. Our dilemma with a multitude of different types of groups we have is how to discuss with people, to convince them that these groups, they will have a better experience. So my challenge to, I'll say the Department of Family Medicine, though I'm not sure how it's represented here, to be honest, would be to have one of the behavioral health specialists figure out the language that the front desk needs, the language that the providers need to communicate the importance of the group atmosphere. Because I as Mark said, it is much more magical than the individual. And to get them to accept coming in to these groups.
Yeah. Good, thank you. Kevin, is your hand still up, or is it up anew? Ah.
No, I had a quick observation based on Mark's comments. I think he's exactly right. And one of the things we worry about, and I think we increasingly need to worry about as an overall healthcare system, is trust in the system. I think the pandemic changed a lot of things. And when we look at our patient population, we're seeing decreases in the willingness to get an annual flu vaccine, for example, because of that penumbra, if you will, that was spread because of the COVID vaccine. And I worry overall, and maybe that's a cultural issue unique to the population we serve on the Eastern Plains, but I really worry that fundamentally on any of this, and I'm intrigued by the idea of group wellness visits, it's about trust with that system, that these people actually have my best interests at heart. And I get it, we're a system and we sort of describe ourselves with that, but that to me really comes down to personal relationships. At one point in the conversation, there was the discussion about who is actually providing the care or asking these questions. And that trust is so important. But I have great worries about it right now with the increasing distrust of the healthcare system, as evidenced by a reluctance to participate in any kind of vaccine process.
Yeah, boy. Yeah, that's right. Trust came up over and over again in terms of what people are just willing to discuss, what they're willing to disclose. David.
One, this is fascinating, and having heard this earlier versions of this, it's really interesting to see where it's come to. My question is why you're doing this. What is the use of the thing that you produce? Because when we started this conversation years ago, it was, well, we want to move from sick care to thriving. Okay, well, how do you measure thriving? Well, it's more than medical. It's got these other components to it. And it's more than the neighborhood you live in and the air you breathe. It's how you feel. So there's a personal component to it. So we started kind of listing and swimming in the literature. And in the face of that, the regulatory bodies are saying, well, actually, you need to have a screening form, a standardized screening form that asks people whether they have a house and whether they're safe and at home and whether they have enough money. So that there's kind of a push there to, and the purpose of that is to try to refer people to social drivers of health fixes. You're not doing that. You're doing something quite different than that, and it's really focused on the individual. The exploration that I've been involved with is trying to measure when organizations come together holistically around a set group of people and try to help them thrive. How do you measure whether that's working or not? You're not doing that. You're doing something related to that. But what is the and it sounds like it's really focused in the medical part of that broader whole. What is the organizational purpose of the thing that you are trying to develop when it is developed?
Yeah. I think there are at least two circles in the Venn diagram here that have quite a lot of overlap, David. But and that is, on the one hand, CMS is paying for this. They are asking for this information. They were hoping, I think they are no longer, they were hoping for an instrument that could actually be administered that would give a comprehensive, more comprehensive than they use now, a comprehensive assessment of people's overall health and thriving, because they have come to recognize that what they pay for in terms of health, mostly through the healthcare system, is insufficient. It doesn't necessarily lead to people's health. And so they're looking for something that's more comprehensive so that they can expand the range of financing applied to people's health and thriving. That's kind of the CMS message that's coming to us. For our purposes, we're interested in learning as comprehensively as we can what it takes for people to feel like they're thriving. And what we're learning is they aren't going to tell us unless there's a set of conditions. They will answer questionnaires that have only seriously limited information. And so the tilt is toward a kind of conversation, and probably a longitudinal conversation that gets at this. The business about integrating organizations, agencies, and so forth absolutely has its place as what happens next. In fact, these focus groups have taught us that that better be in place, or we're not even going to talk to you about some of this stuff. If you're just asking, then I'm not going to tell you if nothing's going to come of it. You better already be set up to help us with transportation or housing or food if you're going to ask about it.
Okay, we're getting pretty close to the end of the hour. Let's do maybe one more question from folks, and we will share the slides after this and kind of follow up on how the project progresses. So this isn't the last time we'll talk about it. It's you, Doug.
This is a question for the group, and it stems a little bit from the conversation and from the word I hear a lot, thrive or thriving. Patients never use that word in the focus groups. It's just not. Why did we pick this word? It just doesn't resonate with me as a patient. It's like, that's not what I'm thinking about. Thriving to me is aspirational. These folks didn't use it at all that I can recall. I don't ever remember it coming to the, I'll look again, but why is that word so important for what we're doing here? Because I don't think it's going to resonate with patients.
That's a great question. And actually, I said last question, but what I would like to change to is please respond to that, and then we'll call it. So what do folks think?
Mark?
One suggestion might be to reframe the question into not how do you as a person define thriving or being vital, whatever have you, but rather, what are you missing in your quest to achieve your goals? And that might inform a little bit better on what patients need from their own perspective. What's missing? Is it food? Is it education? Is it money? Is it job? Is it whatever have you? And that might provide a little bit more insight rather than asking them to define their goal.
Thank you, Mark. Thank you. Very helpful. Jeff.
Thanks. It's been a fascinating conversation, and coming from over 30 years in a public health background, it's something that we struggle with. One of the things that I had heard towards and I retired in 2021 and have been helping support public health. But one of the things that I remember towards the latter part of my career was that physicians were actually on the higher end of who's trusted in terms of when people talk. And I don't know if that was part of the research or if you saw that, but getting those kind of answers really, in my opinion, takes strong relationships and trust. And it was interesting to see at the time that I saw the research, and I can't remember it, that physicians were high on that list of trust, probably because most people that go to their physicians have some kind of relationship with them is my assumption, but I don't know the answer to that. Yeah. The thing that strikes me with this conversation is that this topic is so huge, and it's clear after hearing this presentation that there's massive barriers to moving this forward. And I keep going back to knowing that healthcare policy and finance and ACC 3.0 are starting to focus on how do we integrate more social determinants of health. I do see crossovers. So I saw the words you used in the early presentation, and several of those things were social determinants of health. So is there a way to take a smaller step to try to get some of these answers that would help support a system that can also refer? Because at that point, to me, is so critical when I listen to this. not just asking the question, but do you have a system then set up to be able to make that referral so that there is supports for that person that's bringing that problem up? And I think the more you demonstrate that that can be a connection, if there's a solution to it, the more trust you build.
Beautiful.
All right, Richard, you're the actual last one.
Well, this is our first time to be in part of this group, and I just want to thank everyone for this topic because our whole company's focus is on helping people thrive. And this has been a wonderful conversation that we can certainly learn from, and certainly glad to participate in future conversations on this topic. So thank you for what was shared today.
Thank you.
Yeah, thanks, Richard. And thanks to the whole team that presented today. I think really important content, and that we will come back to it as the project finishes up its kind of next year and final step and figure out what's next. So thanks for being here. We've got another First Friday next month, and happy weekend, y'all. Have a great one. Oh, go ahead.
There's some important references and comments in the chat. Is it possible for the people who are on this call to access that information?
Yes, I believe that Linda was the host and then it became you as the host. So I'm going to sort out yes, you. I'm going to sort out who owns the hosting, but everything has been recorded, including meeting chats. And so I'll follow up with the Vitality Science team once I figure out the technology. Sarah's out of the country, so I don't know what the hell's going on, y'all.
Okay.
So I'll figure it out and follow up.
Okay, good.
Okay, thanks.
Thanks.